Hello and welcome back. This is Professor Harkirat Bal, and today's presentation is about a post-traumatic stress disorder or PTSD. Let's explore what PTSD is and how we can help individuals suffering from it. Also, a quick side note, this lecture should be watched after the anxiety lecture because I talked about etiology and especially the role of amygdala in anxiety. I think that's an important framework. So make sure if you haven't watched that lecture yet, do that first and then come back to PTSD. Remember, fear and anxiety is a normal response to trauma. Most of the people recover very well from the trauma, but those who do not, and if their symptoms continue beyond the expected time frame, then perhaps they fall into this pathological condition, something that we call PTSD. And yes, PTSD is a type of anxiety disorder. PTSD isn't just about a fear. It's a serious mental health condition that develops in some people after they experience or perhaps they witness a traumatic event. And these events might include combat exposure or natural disasters, perhaps car accidents or personal assaults, either physical, mental, or sexual, and so forth. Let's begin with how PTSD is diagnosed. The very first requirement, known as criterion A, involves exposure to trauma. So we must meet this requirement. There are 4 different options, and a patient needs to meet either one or more of the following. So A1 is direct exposure to a traumatic event. Number 2, or A2, is perhaps a client is telling you that they witnessed in person. A3 is that they found out that traumatic event happened to a close person, either family or a friend. And A4 is maybe they got exposed many times as a first responders. For example, you may have a healthcare clinician or a firefighter or a police officer who got exposed to maybe, let's say, a child abuse or some other type of a traumatic events. Please understand that PTSD isn't always about what happened to the person directly, but the overall impact of either they witnessed or being exposed to that trauma. So any of these A1, A2, A3, A4 options can apply. And you may have a combination of one or 2 of these. Also, a very quick side note, a very interesting fact, if you will, that A4 does not apply to exposure through electronic media. For example, looking at some pictures, maybe watching a movie or a TV show. That type of exposure does not meet A4 requirement. Unless that exposure is work related, then at that time a patient will meet criterion A4. Okay, so criterion B focuses on intrusion symptoms. At least one of these symptoms are required to meet this criteria, and these symptoms include persistent unwanted memories or dreams, flashbacks, when the person feels as though the trauma is happening again, and sometimes even the reminders of the trauma, for example, sounds, smells, or images that can trigger psychological or physical distress. I remember one time a client told me that he feels he's haunted, and he never knew when the trigger is coming. The entire trauma would play out in front of them. Sometimes nightmares are so disturbing, so distressing that they avoid sleeping. And remember, we talked about this concept that sleeping is a psychiatric vital signs, a very, very important concept when we talk about PTSD, anxiety, and insomnia, and nightmares. These things are connected. And then in a few minutes, when I talk about treatment, we'll talk about nightmares as well at that time. I don't know if you have watched movie American Sniper. I think they did a wonderful job in the movie to really go over the diagnostic criteria and flashbacks and so forth. So if you haven't seen that movie, I highly recommend that. Okay, so criterion C involves avoidance. So that's a theme here, right? So the client is going to avoid. So you need at least one of these two. So after trauma, these individuals may go out of their way to avoid thoughts, feelings, people, places, or objects, anything that remind them of the event. Now, this isn't just about a discomfort. It's actually a protective response to help avoid the pain of re-experiencing the trauma. But over time, it really limits their recovery, though. So there's a overall impact of this. Criterion D is something that we call negative cognition and mood symptoms. So it has to do with the changes in cognition and mood. So you need at least two symptoms, and these include memory gaps about the event, persistent negative thoughts like I'm a bad person, or feeling of blame, emotional numbness, or a loss of interest in previously enjoyed activities. Remember, this is also a part of a depression criteria. So overall, we are dealing with anxiety and PTSD and perhaps some depressive symptoms. So you have to be very good with your patient history and data collection. And these cognitive symptoms and emotional shift, they deeply impact their self-esteem and relationship. Okay, so criterion E focuses on heightened arousal and reactivity. You need two or more of the following symptoms. So the first one on the list is irritable behavior or angry outburst. Patient may report reckless or self-destructive behavior. They may be on constantly on edge or very hyper vigilant, if you will. And they may also report trouble sleeping, insomnia. We'll talk more about this issue under treatment plan management. And they may have a concentration issues. Overall, these symptoms can be very exhausting for the person and very disruptive in daily life. Okay, so far what we did from criterion A through E, we talked about symptoms, the symptoms presentation. Beyond the symptom clusters, we also look at other criterion, F, G, and H, and that has to do with duration. So you have a client where symptoms must persist for more than 1 month. Then we talked about criteria G, where the symptoms must significantly impair social, occupational, or other important areas of functioning. And I'm sure you know this by now, that this is a very common requirement for many other mental health issues like depression, anxiety, that make sure that these symptoms are causing distress or has a negative impact on the ADLs. Also, criteria H, very, very common requirement, that make sure we rule out other things. Make sure these symptoms are not caused by substance use disorder or any other psychiatric condition or any other medical condition. In other words, make sure you have your differential diagnosis, rule them out, and the best way of doing that is by collecting very good history and asking good questions. So the history is important, right? This is just a FYI slide. There are some specifiers that needs to be considered. For example, PTSD may present something that we call dissociative symptoms, such as depersonalization. This is when you have a client who feels detached from themselves, or derealization, where the world feels unreal to them. Another specifier is a delayed expression. This is when full diagnostic criteria is not met until 6 months after the trauma. Now, everything that we talked about from diagnostic standpoint of view applied to someone who's an adult or a child who is over 6. What if you have a client who's a 4-year-old, 5-year-old? So in young children, PTSD looks a bit different. So therefore, a child less than 6 years, the diagnostic criteria is developmentally adjusted, and that makes sense, right? Because a child may have difficulty express themselves. Now, children may reenact the trauma through play or show new fears and behavior changes, and fewer symptoms are required to diagnose a client with PTSD if the client is minor. Now, there are some other associated features. PTSD can include other concerning features such as developmental regression, for example, all of a sudden like a language loss, auditory pseudo hallucination. So this is not your typical client with the schizophrenia, if you will. So again, history is very important. That's how you will rule out these things. Or perhaps a client with emotional dysregulation and a high risk of suicide, especially when there are comorbidities are present, right? So these associated features remind us why comprehensive care is very, very important. So what's the prevalence and risk factors of PTSD? It affects around 6 to 8% of Americans over their lifetime. According to DSM-5, the rate is higher among veterans, first responders, and survivors of violence or war. Risk factors include early life trauma, low socioeconomic status, pre-existing mental illness, and a lack of social support. And I'm sure you're familiar with these risk factors because they're very, very common for everything else, pretty much, like anxiety disorder and depression and so forth. These risk highlights the need for both prevention and early interventions for these clients. Okay, what is the cultural and gender consideration for PTSD? Well, culture and gender play a significant role how PTSD presents. For example, in some culture, a client may express psychological distress more through physical symptoms. Women tends to have higher rates and a longer duration of PTSD, even when trauma exposure is comparable to men. Culturally competent and gender-informed care is the key in psychiatric care. Okay, so before diagnosing someone with a PTSD, we must rule out other conditions. It can resemble acute stress disorder, maybe adjustment disorder, major depressive disorder. OCD is a very good differential diagnosis. Anxiety disorder, ADHD, perhaps personality disorder, like a borderline personality disorder maybe, and you may have a client with a traumatic brain injury and giving you these presentations. So very good history and thorough assessment is the key. Okay, so what are some comorbidities that can occur along with the PTSD? Well, PTSD often co-occurs with conditions such as bipolar or depression, substance use disorder. In children, you may see ODD or separation anxiety disorders. Now, the functional consequences of PTSD are significant. It can really impair, these clients through social, academic and occupational functioning, poor quality of life. The impact extends far beyond mental health. It really affects these individuals in every domain of life. All right, let's talk about the treatment options now. Well, just like anything else in healthcare, we would like to start with the non-pharmacological interventions first. So the evidence-based, the most effective treatment for PTSD begins with psychotherapy. Trauma-focused therapy like a CBT or prolonged exposure therapy to trauma, or cognitive processing therapy, the way you process things, especially trauma now. And another interesting therapy that we use for PTSD is called EMDR. Now, EMDR stands for eye movement desensitization and reprocessing. Now, it might sound a bit technical, but the idea is actually pretty fascinating. I love this treatment modality. So what happened is, during EMDR, a person briefly focuses on a traumatic memory while also following back and forth eye movements, or sometimes even tapping or sound. Now, what happened is, this process helps the brain to reprocess the trauma, in a way that makes it feel less intense now and more manageable. The idea is that the brain gets a chance to finally file that memory away properly. Okay, so it doesn't keep bothering them. At least it's manageable now, right? It doesn't keep intruding. A lot of people actually find EMDR very helpful, especially when CBT or other talk therapy alone hasn't worked. Now, another approach would be, of course, group therapy, mindfulness, family therapy, family involvement, and so forth. Okay, so that was psychotherapy. As far as medications are concerned, we can start off with SSRIs like sertraline, which is Zoloft, or paroxetine, which is a Paxil. Both of these medications are FDA approved for PTSD. If that doesn't work, we can start with SNRIs such as venlafaxine, which is Effexor, that can be used. Now, Another very interesting agent, drug classification, is alpha-1 antagonist medications. These medications are used for nightmares. So I'm going to spend some time on this because that's a very important concept, very important symptom in the setting of PTSD. So what happens is, well, first of all, these two agents, prazosin and doxazosin, Minipres or Cardura are the brand names. We use them. I personally use Minipres a lot, actually, like a 1 milligram once a day, and I increase that maybe to like a 2 milligram or so in a couple of days or so, 3 to 4 days, 1 week. The idea behind this is, let's talk about alpha-1 receptor. Remember, the during flight or fight response, when you have a client dealing with a sympathetic mode, if you will, right? In case of a real threat, we need norepinephrine. We need to increase blood pressure so that we can run, we can fight. That's normal, right? Anytime you are in danger or you are under stress, we need to increase oxygen and blood pressure and so forth. And alpha-1 receptors play a very important role. What happens is, alpha-1, they cause vasoconstrictions. So when you cause vasoconstriction, you are going to increase blood pressure, and that's a good thing. We need to run. We need a lot of blood, especially in our brain and in our muscles, to think and run. Now, at the same time, norepinephrine is increased. That's a normal response under stress. We need to increase norepinephrine. Remember, norepinephrine also plays a very important role as a neurotransmitter that regulates input to amygdala, and amygdala is where anxiety lives. We talked about that concept before in my previous anxiety lecture. So what happened is, when you have a client suffering from PTSD, they are in a chronic stress state, if you will, right? So they have increased level of norepinephrine even at nighttime. Normal physiology is, when we are sleeping, especially during REM sleep, and that's where most of the dreams occur, right? Norepinephrine level at that time are usually low. That's normal. However, clients with a PTSD or any client in a chronic stress, their norepinephrine levels are high. They remain elevated even during REM sleep. Now that will really disrupt their sleep, and it can lead to those vivid, very disturbing nightmares, especially those that replay traumatic events. So these clients, they wake up with difficulty breathing and with increased pulse or blood pressure, right? Because they are under the response of a sympathetic nervous system, if you will. So what we can do is, we can give them alpha-1 antagonist. So these are alpha-1 blockers. So when you block the alpha-1 response, what you're doing at that time is, you are actually, I want to change the color here. Okay, so you're blocking the alpha-1. By doing so, instead of vasoconstriction, now we're going to do vasodilation. So that will, number one, will cause decreased blood pressure, and also it will decrease norepinephrine, and these clients are able to sleep, or this helps with nightmares. Now, because we are causing vasodilation, these are alpha-1 antagonists, alpha-1 blockers. So a good patient teaching on hypotension as a side effect. Remember, our patients are taking this medication at nighttime. That's when they need most of the support, right? And if you have a patient who is also on some other medications for their blood pressure, maybe beta blocker or calcium channel blockers, and they're taking these medications, they can really have a significant drop in their blood pressure. Also, if you have a client who's taking medication for maybe erectile dysfunction, such as Viagra, that can cause increased hypotension. So a good patient teaching on orthostatic hypotension and so forth. We like to avoid long-term use of benzodiazepine, or any use for that matter, for a few reasons. Number one, we know that benzodiazepine has a great dependency problem, right? Abuse risk. And also, I think the most important issue here is that benzodiazepines, they really don't help the patient. They really don't allow these trauma to be processed properly. So we really need to provide psychotherapy and give them SSRIs or alpha-1 blockers, and perhaps consider benzodiazepine for a short-term treatment for a couple of days, maybe a week or so, 10 days as needed, so that the SSRI kicks in. So that's a very good patient teaching why we are not going to give a lot of benzodiazepine for a client who's suffering from PTSD. All right, well, let's see if you were paying attention or not. Okay, so let's apply what we have learned. So here's a case study that will help you to apply the diagnostic criteria and come up with a management plan for him. So let's meet my client John, who's a very pleasant 36-year-old African-American male with no prior medical or psychiatric history. He presented today in the clinic after 3 months post high-speed motor vehicle accident with no head injuries. He witnessed death of his close friend in the car. He continues to experience flashbacks, nightmares, and intense distress to triggers, for example, sirens. He avoids driving and conversations about the crash. He's also reporting feelings of guilt. He states, "It should have been me." He says he feels broken. His mother, who's also present today at the clinic, she reports that John is withdrawn, has lost of interest in hobbies, poor sleep, he's very irritable, and has concentration issues. He has no history of substance use. The rest of the history and exam was unremarkable. So what I'm going to have you to do is pause for a few minutes and take a look at this slide and answer the questions in the next slide. Okay, so to analyze the case, I want you to answer these 7 questions. Question number 1 through 5 has to do with the diagnostic criteria. So please let me know how he's meeting criterion A, B, C, D, E, F, G, and H. Once you do that, then I want you to answer number 6 and 7, which is come up with a treatment plan for him. Start with the non-pharmacological interventions, what type of psychotherapy you'll do, and then of course suggest a pharmacological plan and provide some psychoeducation for him. And also number 7, see if we can come up with some clinical endpoints for him. So suggest at least 1 short-term goal and 1 long-term goal. I'm going to have you pause for now, go back to your outline, take a look at the case one more time, and see if you can answer the question. Then I'll see you in a few minutes, and then we'll do the case together. All right, welcome back. So, well, let's see how we did. We can do this together now. So question number 1 through 5 was a part of the diagnostic criteria. So, well, our client, he met criteria A through direct contact. Remember, he was a part of the accident, and he also met A2, which is he witnessed death of his close friend, right? Then he met criteria B because he has a clear intrusion symptoms. He has a flashbacks, nightmares, intense distress to those triggers, example sirens. Okay, so criteria C was also met. Remember, he's avoiding driving and even crash related conversations, so he met criterion C. Criterion D is also meeting. His negative cognition include guilt and withdrawn. All right, how about criterion E? Well, he is giving us enough arousal symptoms that include being irritable, poor sleep, and he also has a poor concentration issues. How about criterion F? Well, his symptoms have lasted over a month. So this is after 3 months. So this is beyond the minimum requirement of 1 month. How about criterion G? Well, clearly there's an impact on his daily activity of living, right? Daily functioning. So he's meeting the criteria. How about criteria H? Well, that's where the differential diagnosis come in, right? So we have ruled out the substance use, depression, so that was ruled out by history, right? And he also has no other specifiers like no dissociation or delayed onset is present. Next, the treatment plan should include psychotherapy such as maybe CPT or PE, EMDR, so just pick one and then give a very good education on it. Now for psychopharmacological interventions, since he's not on any medication, so we can start him on SSRI, maybe pick any. So Zoloft is fine, sertraline I should say, and give very good education on that. Talk about the side effects and how it takes a while for the medication to kick in and so forth. Okay, also it's very important to involve family. And number 7 was the goal, the clinical endpoints. Number 1, short-term goal may be to focus on sleep. I think that's important, and perhaps safety, travel safety. And a long-term goal can be target trauma processing, how we can process that trauma and how we can regain that functional ADLs, able to go back to the community without any hesitations, if you will. Pretty much, the long-term goal would be to go back to your prior level of function. All right. And in conclusion, PTSD is a very complex disorder that requires a very comprehensive, trauma-informed and culturally sensitive approach. Recovery is possible, but it takes patience. It really requires very, structured care, if you will, and often a multidisciplinary team. You need somebody who's very good at providing psychoeducation and so forth. Well, thank you for your attention, and I will see you next time with another topic. As usual, if you have any questions or concerns, please do not hesitate to contact me. Thank you.